So today we have this session on COVID vaccine for cancer patients, and this is a second version of that because so many new things have come in place, and we are privileged to have none other than Dr. Senthil Rajappa to moderate the session. And Dr. Sahu and Amish are my co-program directors for this program. We are now moving into our 14th series. The expert panelists include Dr. Nikhil Gadial Patel from Hyderabad, Dr. T. Raja from Chennai, Dr. Hemant Malhotra from Jaipur, Dr. Ullas Batra from Delhi, Dr. M.V. Chandrakant from Kolkata, Dr. Vinayak Makka from Bangalore, Dr. Ashay Karpe from Mumbai, Dr. Mukul from UK, as we heard, and Dr. Vishu Bhasin from Delhi. And he is representing the lab. So we will really have a lot of question and answers going there. So with these introductory words, may I pass on to Dr. Senthil to proceed.
Thank you so much, sir. It's my pleasure to be here this evening. And I want to thank again Amish and Sahu also for asking me to do this. So today's panel discussion is on COVID vaccination and cancer. Why, what, when, and why not? So there are so many things that we're going to discuss in the next hour or so. So the first thought that came to my mind the moment we, when sir asked me to do this topic is, do we know anything at all? Or we know so much, but we're not really clear about what is right and what is not. So let's get into it. So it's time to focus on the vaccination. This is June 7th. That was the second wave, a humongous second wave, overwhelmed everybody. There was a lot of loss of life and so on. We've been in the midst of it. But the good news is that this is waning off. And as of yesterday, the count was 88,000. It was just over 4 lakhs at the peak. So we are very happy. We're delighted that we are seeing at least the wave coming to an end, though very, very slowly. So as this cartoon here very clearly shows that the best way out of this is to vaccinate, right? So yes, COVID behavior, COVID appropriate behavior, as they say, is now the norm. So in spite of COVID appropriate behavior, we know that we are not so good at following it, but the best thing to do to get out of the pandemic or prevent another big wave is to get vaccinated. And today, in the next hour or so, we will discuss about vaccination. We will start with why cancer patients should be a priority. And then we will go on to some general remarks regarding the available vaccines, especially the ones that are available in India. We will then speak about whether these vaccines are really effective in cancer patients. Do we really have any data? We have a lab person with us today, Dr. Bhasin. So we will quiz him on, the various tests that are available today in order to say whether the vaccine is efficacious, at least those lab parameters, which are supposed to be surrogates of efficacy. And then finally, we will also touch upon when to vaccinate, which is another important part of today's panel discussion. So let me start with the senior most of the panel today, Professor Hemant Malhotra. He needs no introduction. Sir, are cancer patients a priority for vaccination? And if they are, why is that so?
So my answer to your question, Senthil, is that unequivocal yes, cancer patients are a priority for vaccination because they have, compromised immune system, and they are more prone to the viral infection. And if they do get the virus, then they are much more prone to a severe infection. They are much more prone to be hospitalized. They're much more prone to land up in the ICU. And they're also much more prone to die because of the COVID infection.
Right.
So cancer patients are a priority for vaccination. Why? Because COVID is much more severe in them. I think that answers your question.
Absolutely, right? Absolutely. You hit it right there, sir. Sir, cancer patients, when they get COVID, are likely to get into trouble more often than patients who don't have cancer. And so it's very important that we make this a priority for all our patients. Chandrakant, are all cancers equal in terms of getting into trouble? When I say all cancer patients, does it depend upon what cancer you have? what treatment you're taking. Do all these have a bearing on whether we get into trouble or not, Chandrakant?
Definitely, sir. Cancer is a heterogeneous thing.
Right.
The stage, whether it is solid tumor, whether it is hematological malignancies, what type of treatment they are receiving, all these matter. The worst to have is a hematological malignancy with a T and a B cell immunosuppressive therapy.
Right.
And the best to have is an early stage disease receiving hormonal therapy. So it's a heterogeneous population, as you have stated, sir.
Excellent. So we've got a big bunch of very heterogeneous patients there who have very different outcomes when they get into get COVID infection. Vinayak, if you look at all the meta-analysis, all the series that have been published on cancer and COVID, the mortality seems to range anywhere from about 5% to 65%. And one of the reasons is what Chandrakant actually pointed out. Now, the question that I want to ask you is that, is this related directly to the cancer? Because there are some meta-analysis which show that the cancer itself may not be the reason for the mortality, but the associated comorbidities may be the reason. What is your experience and what is your opinion on this statement? Because there's both sides to it.
Sir, I think I agree with our Chandrakant that it is heterogeneous.
Right.
And I agree with you, it's not just
not just cancer.
Malignancy itself is the problem. Even though we have seen that, especially myeloma, they almost, from first wave, we almost lost out of 10 patients who had myeloma disease, 8 patients died of it. And patients who survived are the patients who were in control, right, like post-transplant in remission. So one thing is, there is disease aspect is there. Apart from that, comorbidities, usually cancer is of elderly age. We have a lot of comorbidities. And second part is what I felt is those people need extra care. Even the patients who I lost myeloma inside the COVID ward, there was no one to take care of him, no one to help him to bathroom, and he collapsed of hypoglycemia in the bed. So there are a lot of other things other than disease, comorbidities, even not able to attend also matters to the care.
Excellent. So I think there are so many issues which will impact whether somebody dies or not, starting from the disease, the treatment he or she is on, the stage of the cancer, what cancer it is, and whether there is good nursing care and, of course, good treatment in the hospital they are in. Dr. Acharya, let me bring in you here. Is that the experience in the UK also?
Well, I mean, yes, you're right. People who are actually quite well controlled on, therapy, chemotherapy, will obviously have definitely better prognosis, because they're, they are not sort of, they are not very prone. But those who were not very well controlled, whose immune system was absolutely down and out, were the one who obviously fared quite badly. There was an important question that you asked, we just sort of, why do we need to vaccinate people, with their immune system suppressed, people on chemotherapy or people with cancer? Obviously, because they don't fare very well. COVID-19 is a very vicious disease. It does strike. But when you look at the flip side, see those patients who do not have a very good immune response, and if they are treated in the hospital.
Dr. Acharya, just sorry to interrupt. We are coming to the immune responses in cancer patients later.
Okay.
I just want you to comment upon, is this what you see, all our panelists have said? Okay,
absolutely. It is extremely important, that our cancer patients are well treated.
So all of us are on the same page.
Mortality is very bad.
Absolutely. Agreed. So all of us are on the same page.
Sure.
We agree that cancer patients are a very, very important priority for vaccination, and we should push forward to get them vaccinated, right? So here we are. So this is where vaccines have reached. This was in our group a couple of days ago, that today in a matrimonial column, you start seeing things like this: Covishield vaccinated, both doses, and so on and so forth. And that's where it's getting. Vaccine efficacy against SARS-CoV-2, something that we keep on discussing time and again. Don't you think the efficacy of the vaccine is simply too good to be true? Nikhil, what is your opinion? You see 90%, 92%, 95%. These are not, it's like your intermarks in Andhra Pradesh, right? So that's how it is. What is your opinion on this, Nikhil? Because this is something that people keep debating. Is it effective or not? I saw a question which said, there were so many doctors who were killed. Is there a role for vaccination at all? Nikhil, what do you think?
So we are still searching for the final answers, but having said that, we all, rather I would like to believe over here that vaccine vaccination has shown its efficacy. Now there are different ranges. There are different reasons also. We also do not know which strain, which particular strain hit one particular doctor or whosoever it is, who probably had struggled in his life despite vaccination. But the amount of mortality what we had seen is extremely small. So in general, it has at least shown to improve the infection rate for sure. And also in term, if at all patients got infection, they got usually very mild course. So it has its efficacy, and that's how we should normally look at the efficacy, not only in terms of mortality.
Absolutely. And let me ask you, Nikhil, on that breath, are we trying to prevent just infection, or with vaccines, we are trying to prevent the severe COVID and mortality because of COVID? Because this is another misconception. We think, or rather people think that, you take the vaccine, that's about it. Is that what we are trying to prevent?
Absolutely. I mean, even if you get lesser COVID, I think anybody can take it, considering the kind of disease what we are looking at. So we are more looking at the severity and mortality probably, and probably lesser at in terms of the actual percentage of infections.
Excellent. Dr. Acharya, I want to bring you in here. You're a microbiologist. You must be knowing better about vaccines than all of us. Do you think the efficacy of the SARS-CoV vaccine is way beyond many of the other vaccines that we have approved and used in the community?
So you're saying comparing the vaccines, the COVID
vaccine versus
against
COVID versus
routine
BCG.
Vaccine like hepatitis.
Yeah, correct.
Okay, fine. You see, the first part of the answer is it's been only 6 months since we've actually started giving the vaccine. The first dose of vaccine was probably given in December, Pfizer dose. So we've not really seen, we don't have a long follow-up. So it will be very difficult for us to say at this point how effective they are. Which, when I say how effective, which means the duration. Right. So we probably have to spend at least a couple of years before we can compare it. But yes, why are vaccines important? Yes, they are important not only basically to prevent the severe form of disease, to prevent hospitalization. It brings down the hospitalization significantly, to prevent mortality. Plus, we've also found, as our recovery trial keeps, running on parallelly, we've seen it not only produces IgG antibodies, it also produces IgA antibodies, which are the mucosal antibodies, and that actually does bring down the transmission.
Absolutely.
So that is the only way of giving rise to what we call as herd immunity, the very cliched term which has been used.
Absolutely. We'll come to herd immunity towards the end. You're absolutely right that the efficacy, at least from the clinical trial standpoint, seems to be very good compared to the many other vaccines that we already have in the market. But your point is absolutely correct that we will have to wait for a little longer before we say that it is as efficacious in the long run.
True.
Yeah, so great. Sir, Hemant Malhotra, sir, does the technology matter? Efficacy, adverse event profile, we've heard about thrombotic events and all that. What would be your opinion?
So I think I agree with Dr. Mukul on a lot of fronts, in the sense that this is actually an unprecedented situation. Humankind has never faced this situation. There is no precedence. There are no big clinical trials and experiences to go on. We've had the vaccine only for 6 or 8 months. And again, you have the mRNA vaccine and the more traditional vaccines. We do know, in the trials which have been done, on the efficacy of the vaccine, both in terms of producing the antibody and secondly in terms of preventing the infection. Some numbers have been quoted, 90 plus for the mRNA vaccine,
correct,
between 70 and 90 for the other vaccines. But still a lot of information is lacking, and there have never been any head-to-head comparison between vaccine, and I don't think it is going to happen. And people are also saying that you do the first dose of one vaccine, second dose of the other, so it's all a little bit of hodgepodge.
Correct.
In one unequivocal message which the world can understand is that vaccines are effective, should be given. Whatever vaccine you can lay your hands on, take that. And as of just now, 2 doses are needed. What is the difference between the 2 doses? That again is a matter of controversy.
Excellent.
So, like the picture you're showing on this slide, I really like this. Trump is never going to permit Putin to vaccinate. I guess some of these answers are never going to happen to us.
Absolutely great. Sir Purvish, sir, please go ahead. You wanted to make a point.
I was actually going to say some similar points to what Hemanta said.
Yes.
That first of all, when we talk about too little time and too much development, we must also remember that technology has advanced immensely.
Absolutely.
And everything has been telescoped in the development because of technology. There has been no shortcut taken in the development of the vaccine.
Correct.
And I think we should not forget that. That was the additional point I wanted to make.
Great. So I think everybody is convinced that the vaccine is efficacious. It's not only in the clinical trials that it has been effective. Sir, Purvi sir, would you want to respond? There was a question in the question box, saying so many doctors have died. Is it really worth vaccinating? We've discussed this point so many times in our meetings. And so what is your answer to this?
So we did a survey on that. And actually the number of deaths for people, the doctors who have been vaccinated and have taken both the dose at least 2 weeks earlier is very small, very minuscule.
Correct.
So many of the deaths actually occurred after the first vaccine or immediately after the second vaccine. So at the time when the immunity had not really fully developed. So we have to take all that with a pinch of salt.
Absolutely. And in fact, the breakthrough infections is in single digits and the mortality after 2 doses is hardly any. So I should not, I think we should not go home today with the impression that everybody who takes the vaccine will never have the infection at all. Please remember that vaccines are supposed to prevent severe disease, moderate disease, and death due to that particular infection, not just the infection itself. Ullas?
Senthil, yeah, hi. I was
nice. Go ahead.
I see for the first time politely I have raised my hands on the Zoom chat over there.
I knew when I didn't see your hand, I knew you were going to raise it. Please go ahead.
So we have had 700 people of cancer,
right,
whom we called up telephonically in the last 1 month to ask whether they got vaccine or not.
Right.
29% of people got vaccinated. That is around 219 people got vaccinated. 520 people did not get vaccinated. Out of this 219 people, 32 had COVID infection.
Right.
None of them required hospitalization. None of them died. Out of the remaining 533 people, 117 people had a COVID positive disease, and out of this 14 died. That is 12% of people with cancer and who did not get vaccinated died.
Right.
So I think that's a very strong data, and I've given it for why I have a quote in my hand is because we are giving it for publication in CRST. So absolutely right, cancer people should be vaccinated. It only reduces the severity. It doesn't prevent against infection.
Absolutely correct. So that has been our experience also. When you see patients coming back to you for chemotherapy after a 1 month break and you ask them what happened, they tell you they had COVID. Were you vaccinated? Yes. Did you have symptoms? Hardly any or very minimally symptomatic, and all of them, nearly all of them have made it back to the clinic for their next line of chemotherapy. So I think what you're saying is absolutely right, Ullas. There's no doubt about it that there is efficacy. We can debate how much of efficacy is there in cancer patients, but I personally at least don't have any doubt that there is some efficacy in cancer patients, that's for sure. Now that Sputnik is in, let me ask Dr. Acharya again. Dr. Acharya, Sputnik has got 2 different adenoviral vectors, the first dose and the second dose. And one of the, so-called, within inverted commas, problems with adenovectoral vaccines is that they think they might be antibodies to the adenovirus itself, which might blunt the immune response to the virus, especially when you're doing booster doses. Do you think this is just theoretical, or is there a good reason to believe that Sputnik might be superior 92% based on the clinical trial? What is your thought?
Okay, so basically you're saying that Sputnik might be superior to the AstraZeneca.
Might be. Is that, do you think there is some substance to it? Or
yeah, okay.
Please go ahead.
So, see, the only difference between Sputnik vaccine and AstraZeneca, if you compare like to like, because AstraZeneca is also adenovirus, is basically the vector for Sputnik virus, number 1 and then second dose is slightly different. So they have tweaked the vector because they feel that by giving the first dose of adenovirus based vector vaccine, the person will obviously produce antibodies, which can itself then nullify, kill the second dose, the second adenovirus. So the actual adenovirus vector will not be able to reach inside the cell and therefore may not give rise to a strong immune response. So to evade the antibodies circulating in the serum, they have tweaked the adenovirus vector, and that's all they have done. Is this really sort of practical? The question is, there was a study done in the US and then also in the UK to find out how many people in the population actually have a lot of adenovirus antibodies? And they found that especially these adenovirus are chimpanzee adenovirus.
Yes.
You see, they are not human adenovirus, the one which they use for AstraZeneca, the Sputnik. So they found that less than 5% of the world population would carry the adenovirus, chimpanzee adenovirus antibodies.
Okay.
So really, not being having sort of exposed to the chimpanzee adenovirus, the question of having antibodies present before the vaccine is given actually does not arise. So I don't think that would really make a difference.
So do you think after the first dose there is a possibility of antibodies, or that
well,
also
yeah,
is unlikely?
So in theory they say there is a possibility, but then what we have seen is we have looked at the amount of neutralizing antibodies after the first dose and then after the second dose, and we have found that we've looked at IgG antibodies specifically after the first and after the second dose, and we found that the IgG antibodies do peak within 7 to 10 days of the first dose, and then the peak remains up to the second dose. Then they start waning down. In about 4 or 6 weeks time they go down to 70%. You can safely use the second dose. The antibodies are very unlikely to nullify because the uptake is quite rapid. So it really doesn't matter.
I think you're absolutely.
Senthil,
Yeah, Sahu, go ahead.
Yeah, just a small point, because I feel there's a lot of similarity how the efficacy of the small data which has come from UK, the half dose. The first
Correct.
half dose and the
inadvertent,
full dose,
inadvertent half dose.
Yeah, whatever it is, but
Correct.
you look at it, the efficacy really rounds up to 92%, which is
Absolutely.
the figure of Sputnik.
Correct.
So there could be a point in that the dose of adeno vector, if given lesser, the immune kill will be lower in the second dose. And that could be the hypothesis could have been there in AZ, which is proven in the Sputnik. That's how I look at it.
So I think everybody is correct in their own way.
Sorry.
Yeah, Dr. Acharya.
I'll just come in for a minute.
Yeah, please, quickly.
See, that they realized later, as Dr. Sahu said, it was just an error why they got the second dose. So they halved the dose, but actually they have realized it is not the half dose which causes a better immune response. It is the interval.
Right.
So I think they actually realized that those patients who received the half dose actually got the vaccine for some reason, not in 4 weeks time, but in 6 or 8 or 10 or 12 weeks time. And hence that is how they decided that if you increase the duration, then the antibodies would subsequently wane by the time you give the second dose, and therefore the chances of killing the second adenovirus vector based by the neutralizing antibodies circulating in the serum would be much less. So it is the duration, the interval, which really matters, not the quantity of the dose.
So it is probably serendipity rather than anything.
Correct, absolutely.
But the paper very clearly states.
So we'll move on. So we've got so many things to discuss.
Sure.
So I'm just going to ask Amish, before you ask me a question, I'm going to ask you: do you think there is clinical evidence that these differences actually matter, or as Professor Hemant Malhotra clearly said, lay your hands on something? All of them, at least this point in time, seem to be good. What is your opinion?
I think our clinical experience, as Ullas mentioned, is an evidence. It's enough to say that just vaccinate yourself. That is the bottom line, what is there. My point is, and since you said to move on to Tarini ko, just on that, Dr. Mukul, that delay was there only in UK, but the trial was done in all the 3 countries, and the delay was equally same in all the 3 countries of the Covishield difference in this thing. So I tend to agree with Tarini's hypothesis, rather than it is not just the delay.
I think we just don't know.
Let's move on.
I think you're probably right in a way that all of us know a little bit of this vaccine and the stories behind them. But I think everybody is right in their own way. Absolutely. Sir, Raja sir, welcome. What is your thought on the UK variant, the South African, the Brazilian, in terms of vaccine efficacy with what we have with us as of today? The reason why I'm asking this is, unless everybody gets vaccinated, these mutants are going to keep coming up all the while, and the pandemic is never going to end. So what are your thoughts on the effectiveness of the present vaccines against all these variants that are there as of now? Because that's another point that may be differentiating, though we don't have good evidence. Raja sir, are you there? Okay, if Dr. Raja is not there, Ashay?
basically, again, currently we claiming that, this vaccine will prevent this variant is really, we do not have that kind of robust data, but definitely even with the Covishield, Covaxin, we have data that, fairly we have, we can deal with the UK variant as well as the Indian variant. But I mean, I always keep, thinking about it. The virus originated probably in China, but nobody said Chinese UK variant of China virus.
Except some television channels, I suppose.
Yeah. So basically, I think we are yet to, analyze this. I really don't think so. Because now, people also, maybe sometime back, they're saying Kolkata variant now.
Very
like
good.
Indian Kolkata variant of virus, you have double mutations, you have triple mutations.
Very good. So I don't think we have enough data to say that one is better. Yeah. Amish, what is your thought on these mutants, Amish?
Sorry, I was on mute.
Okay. No, I'm talking about mutants. You're talking about mutants.
It's very, very interesting. Again, I refer to Ullas because Ullas has encyclopedia of data.
Exactly.
So you have to go to Ullas if you want to survive in city of Delhi. Ullas last time said that the reinfection this time he saw only in 4 of his patients among so many patients which he saw. I think if the mutant would have been widely prevalent, the protection from reinfection would not be so much. And the same thing has been seen in Danish study also. So I think that it's too early for us to talk so much about mutant. Only the time would tell which mutant will be working against the vaccine and which mutant would be protected with vaccine.
Exactly. So I don't think we know the whole story as of now. Ullas, because you're good with numbers, I've got some numbers in front of you. The tale of 2 vaccines. This is a paper cutting or a paper cut, should I say?
Talk about the tale of 2 vaccines.
No, it's not the TAIL. We will discuss about that some other day. It's the TALE of 2 vaccines. Do you think this makes sense, or that this is fallacious in the way the study was done and the way it was analyzed in terms of numbers? 500 patients, 400 plus versus 90 patients being compared. With the seropositivity rate. So do you think there is some credence to this, or we should just ignore this and move on?
I think, Senthil, we are just torturing the data.
Absolutely correct.
I think, let's just lay our hands on the first vaccine, get the second dose done, and then just go ahead, move on.
I'm glad everybody is saying the same thing. I'm so happy. The reason is because just lay your hands on the next vaccine that is available for anybody around you who is not vaccinated as of yet. Okay, let's come to this question. Let me call in Dr. Bhasin now, the pathologist. Dr. Bhasin, is protection after infection as good as the vaccine?
Sir, these are a little bit less comparable topics, because protection after the infection we generally measure by using a nucleocapsid protein antibody assay.
Okay.
When I'm looking at antibody response, I'm looking at spike anti-S protein assays. Now, previous to vaccination era, when the vaccinations came, we did not have S protein antibodies assay. They just came in February this year after the vaccination. Prior to that, last year, whatever numbers or whatever antibody assays we are doing, they were focused on N protein. However, so I can't compare with a person who's got disease antibodies and just single vaccination, because I'm looking at 2 different. Okay. However, when I compare the spike protein levels, they are generally always higher or of equivalent to a fully, I never see a low response. That's what I mean to say. When I'm looking at vaccine-induced S protein antibodies, I get a whole spectrum of values. Say the assay which I'm using has an upper linearity of 250. So from 1.2 to 250, I see the entire range. However, if when I see in patients who got S protein antibodies by the disease, they are generally upward of 100. So disease-induced response is always higher or equivalent to a full efficacious vaccine, in my experience.
Okay, so let me bring in then the next question there. Do we know clearly what the serocorrelates of a good protection are? Should it be something to do with the T-cell immunity? Should it be something to do with antibodies? Because we are just doing this one test and then showing this all over the place and saying, I've got antibodies, I am protected. Is the story not as simple as that? Do we need to know beyond this to say somebody has got adequate protection versus not? Because we have reinfections, although with vaccinations, the reinfection rate has gone down significantly. But do you think we are looking at the right parameters to say whether somebody is adequately protected or not? Dr. Basi.
So basically, I can say we are looking at the right parameter, but we still don't know the cutoffs.
Okay.
Right. And we still even don't know that whether there are cutoffs which mean anything. Because if I say, I have seen a lot of patients who had the highest diagnosable titer of antibody, whether I'm doing a Roche assay, the same patients had the highest antibody titers on an Abbott assay or a Siemens assay also, but they still got positive with the mild disease. What cutoffs? You know, if I say, if you have a titer which is 10 times the detectable range or the cutoff index from where it will be called positive, you won't get an infection. If it is 100 times, you will not get severe disease. That number is not known. However, now we are seeing a new range of a new test coming in, which is allowed by the Singapore Health Authority only. US FDA approvals are still pending, which is a surrogate utilization assay. So that will tell us that, say, if Dr. Vishwanath has X amount of antibodies, what percentage of it are utilizing antibodies? But how truthful, how well it correlates, it still remains to be seen.
So I think your point is well made. Though we know there are so many serocorrelates, we don't know what is the best. We don't know what is the best cutoff to say that this is where your protection will be good. Professor Malhotra, do you think these tests are relevant in today's clinical setting at all? Should we do this for somebody and then make any decisions based on this at all?
You know, I'm not an expert on this. I have no qualms in admitting that, but my feeling is that this is not essential. This is not mandatory, and this is not a yardstick which you should use for vaccinating versus non-vaccinating. In fact, I'm not even sure that if you have the infection, full-blown PCR positive COVID infection, whether you should take 1 dose or 2 doses. Like the recommendation is that after 3 months, we should take 1 dose. Then again, this is uncharted territory and nobody is actually very sure what to do.
Okay, absolutely correct. So we really don't know where the applicability of the test is. Professor Parikh is clearly pointing it out that these are used for government policies to look at this zero prevalence rate in the community, not really to make any decisions. Nikhil, there was somebody that I know of who said, I had 1 vaccine dose, now I'll do a serology. And then when the serology starts, if I am having antibodies and the antibody level starts waning, then I will go and have the booster dose. Do you think a practice like that is right? It's inappropriate at this point in time.
So you had 1, I had many.
You had many, great, very good.
And very much in the, including the doctors community also. The reason is I think everybody is learning on this one, on these fronts. Having said that, probably this is still, I believe, is not a very appropriate way of looking at it. Probably something which probably I wouldn't do in that.
Absolutely.
Practice.
I don't think we should do this. Professor Malhotra is absolutely correct that we shouldn't do this in order to make any decisions on vaccination. At least it is to find out how many in the community have been exposed either because of a vaccine or because of the infection itself. Have we reached herd immunity and stuff like that? It should not help you decide on whether to vaccinate somebody or not. Excellent. Right. So,
Senthil.
yeah, Amish.
So what you said right now, I agree with that.
Okay.
In a normal population, yes, these antibody titers may not be meaningful, although I have my doubts about that.
Okay.
But in cancer patients particularly, there's this recent article where cancer patients may require a booster faster.
Yes, we'll come to that.
Normal population. But if you're going to cover that, then we'll discuss at that time.
I'm going to cover that, Amish. I'm going to cover that.
Dr. Senthil, just one question.
Yes, please.
If somebody had the flu, the COVID infection, then what is the status? You have taken 1 vaccine.
Those questions are listed right in front of you. They are questions. So we will get on. Is Raja sir there? Sir, there you are. So,
Hi, Senthil just came in. I had already.
Okay. We'll give you some time to breathe. let me come back to you.
Last question, Dr. Senthil, if you may permit, I want to add something.
Please.
So we are talking about the relevance of the serological test. See, it is for individual, it is useful to determine vaccination failure. The titer may not have a significance, but it is still a good guide, especially in cancer patients, because if you look at the recent study at JAMA and Annals of Oncology also, in multiple myeloma patients, effectiveness has been lower.
Right.
So to pinpoint those patients, now what is still controversial is that if the antibody has not developed, should we going for booster dose or not? That's a controversial area, but we know.
I think there is no answer to that question, isn't it right, Dr. Bhasin? So you may say after doing it that you don't have antibodies, but is giving a booster going to solve that problem? I think that is something that we don't know. So keeping that in mind, I'm not too sure. This is my personal opinion. You know, we can ask the panelists. Most of them have actually typed what their thoughts are already. So I think at the level of the individual also, it's a little dicey to be making decisions based on what your antibody levels are. Anyway, that's my opinion. We can move on. So let me ask Chandrakant, what happens if someone develops COVID after the first dose, Chandrakant? When should that person have their second dose or the booster dose?
So yes, after the first dose, the patient can have a COVID infection because the immunity is less than that of the 2 doses. So I would suggest a number of what everybody states, around 2 to 3 months gap between the infection and the subsequent dose. So I would still go ahead and vaccinate the second dose.
When would that be? 3 months after the infection?
Yes, sir.
Is that correct? 3 months after the infection?
Yes.
Right. Ullas, what is the reason we are agreeing now to delay the vaccination to 3 months after the infection? Is it got to do with some science, or is it got to do with scarcity of the vaccine?
I think it's scarcity of the vaccine, because if I remember rightly, the first CDC guideline said 14 days.
Right.
Then it came to 28 days, and now it has come to 90 days.
Correct.
So they want to get vaccine to maximum people. To me, that is the funda. I don't think it's got something to do with it.
Okay.
We are vaccinators, our center, and they have also given in writing that anybody who has recovered from vaccine, 14 days after the resolution of last symptom, you can vaccinate.
Correct, but isn't the guideline now that you need to wait till 3 months? Am I right? Wrong?
CDC says that.
I think there is an ICMR guideline also which says
ICMR says 90 days.
ICMR says 90 days. I've got that. Anyway, never mind. So
can I just come in? Yes, it was 3 months, but the UK guidelines very clearly say 4 weeks after the RT-PCR test was positive. And that is especially if you're dealing with a cancer patient or an immunosuppressed patient, the earlier you vaccinate,
the better it is.
I would not wait for 3 months, especially in a cancer patient.
So, Dr. Acharya, that brings me the other reason why some people think that you may need to wait for 3 months. One point is that you already got some antibodies, though we are still in a controversy as to whether these are protective, how protective they are. But at least the reinfection rate in the first 90 days seems to be very, very little. So you get some antibodies. And the other argument seems to be that your immunity is down at the time of a severe infection and when you're recovering. So if you give a vaccine at that point in time, the immune response may not be as good as if you gave it a little later. Do you think there is, some substance to this argument?
No.
Okay.
You see,
why do you not?
So when you have an infection with COVID, why does the immunity go down? So, maybe if the patient has received biologics, if the patient has been given tocilizumab for some reason, who's had a severe course, then yes, then you would definitely want to wait for 2 to 3 months, because it takes time, especially after the biologics have been given. But if someone has had a moderate COVID infection who's not required biologics, tocilizumab or sarilumab, there is no reason why you should actually delay the other thing is, yes, if you're looking at a non-cancer patient, someone who's not immunocompromised, there is no harm in waiting for 3 months after the bout of infection who's already had first dose of infection. So this is where you have to prioritize patients. Say for the rest of the population, you can wait for 3 months after the recovery from infection.
Cancer patients, you're saying, should be as early as possible.
I would still stick to 4 weeks.
Yes, we'll come to the duration between the 2 weeks. Raja sir, let me bring you in here. Do you think it's a good idea to vaccinate with 2 different vaccines? Because there are 2 issues to it. One is there is some data that some have wider immunogenicity. The immune stimulation might be better when you combine. The second practical problem we are having now is that one group has got Covishield. They don't have the booster Covishield. So they come asking, can we do Covaxin? So is there again some at least theoretical reason that this might be a better strategy? Because this has been done in cancer patients with influenza vaccine earlier, and they found that the immunogenicity was better. So what are your thoughts?
Disclaimer, I'm one of the least experts on this, but
none of us are, sir. None of us are.
However, there are two reasons why this argument looks attractive. One is that, as you rightly said, now we are in a state where we need to, as Dr. Acharya rightly pointed out, I would not be happy to wait for 3 months post. So therefore, we are looking at prioritizing patients, and then we are now looking at how to ration the supply that is available, meeting the supply and demand, so on and so forth. But on another note, the vaccines are these vaccines are different. One of them is an inactivated vaccine. The other one is actually, one
adenovirus.
So it's actually adenovirus. So therefore, again, there is an argument that is out there that we are all reading that the different variants. At least a few days ago, the Delta variant seems to be more responsive to a certain vaccine, let's say. So I'm wondering that what about other variants? So if we expose the individual to the different components, whether that will finally put him into a good reporter. So probably for that reason, it looks like a mix and match will be a good idea.
Correct. So I agree that we don't have data as of now, at least certainly not in COVID. But there are data sets which are available in other diseases, vaccinated diseases, wherein people have used different kinds of vaccine to increase the width of the antibody generation and also the height of the antibody generation itself. I don't want to go through the summary. I'm sure people have gone through it as I have put it up here. Okay, Ullas,
Sorry,
let me come to... Yeah, please go ahead.
I'll just add here.
Quickly, please.
Yeah, so basically, we have had this mix and match trial going on in the UK since the 8th of January, where we've had 4 arms where we use AstraZeneca as the first dose and sort of, Pfizer or Moderna as the second dose and vice versa.
Okay.
Plus, we also have had a second arm where they use 4-week interval and then 12-week interval. We've had the early sort of results out. And they have actually seen that there is a good boost in the immunity when they have used mix and match of the vaccine. So it is. And there is something called as heterologous boosting, as you rightly said. This has been seen in, for example, hepatitis B. You see a lot of patients who are non-responding to hepatitis B, even after giving them the third dose, the third booster, 016. But if you use a different type of hepatitis B vaccine, they definitely do respond. The same thing was also approved in about 5 years ago by the European Commission for Ebola vaccine testing. So they have found using heterologous 2 different types of vaccine does actually boost the immunity. It also improves the T cell immunity, which we have not actually discussed at all.
Absolutely.
Which is so important here. Anyway.
Absolutely. So you made the right point, Dr. Acharya. I didn't want to get into the immunology of it. It's very important. In fact, T cell will come when we talk about rituximab in a moment. We are 8:15 now. I'll close in another 20 minutes. But when we come to rituximab, I'm going to talk about T cell. Sir, please. Go ahead.
One question, please, particularly to Dr. Acharya.
Yeah.
Yes.
I had continuing the same discussion, Professor Acharya. A couple of days ago, we faced a practical situation in which some countries, when they want you to travel at present, do not recognize certain vaccines. So I thought now that is already existing, and I'm told that most countries do recognize the Sputnik vaccine. So I was considering a travel personally myself, and I have taken the AstraZeneca Covishield 2 doses, but then I was told that probably that may not be enough. Why don't you take 1 shot of Sputnik vaccine and then you are eligible to travel? So my worry was, will I be jeopardizing whatever is happening inside me? That's my personal question to you. And then that's an extension of mix and match strategy. And as Senthil beautifully put it, increasing the width and the height of the response.
True. Well, to be honest, first thing is, I think as far as AstraZeneca or Covishield is concerned, that has been recognized by WHO. So it should not give you a problem of securing visa.
I believe some countries don't yet.
I think there are only maybe a couple of countries in the European Union which probably are causing problems, and that's more to do with Brexit So I think there are more political.
There's more politics than science.
There are more political reasons. As far as getting a third dose, now that's a very interesting point you make. So I've recently read a paper where some of these cancer patients who've had chemotherapy and had really bad immunity, so they have offered them a third jab, a third dose of vaccine to boost the immunity. And the results so far, albeit it's only a small group of patients that they have done, so that is somewhere in US, but they have found that eventually for these patients who really have a severe cancer and severe immuno sort of therapy, type sort of, very, very toxic, they are the patients who probably would do well with having a third dose. So that third dose is definitely going to come. And I think all of us would end up having a third dose maybe in another 12 months time.
Sooner or later. I totally agree with that. From whatever data that is emerging at least.
Yeah. Absolutely. This is going to be like, part of a routine immunization.
Absolutely.
You have to live with it.
Absolutely. Ullas, do cancer patients mount an adequate or a comparable immune response? And is this different with different, cancers?
Yeah, I'm absolutely sure that the responses that a cancer patient will mount is going to be lesser as compared to an immunocompetent individual.
Right.
Anybody on chemotherapy, anybody with a hematological malignancy will obviously have a lesser response. Having said that, I did read an article, I don't remember which vaccine. What they said was that after the first dose, the efficacy was only 40%, but after the second dose, the efficacy, and which was given at 21 to 28 days time, the efficacy was around 80 to 90%.
Right.
So the response would be similar if you do not delay the duration.
Second dose
is very, very important. So to me, again, the data said that we said, our patients got the Covishield in 28 days,
right,
and none of them really had a very severe disease. So probably 2 doses should be good enough. Definitely that second dose should not be delayed. Whether we need a booster dose, I am not so sure.
Okay.
Doing a study for that.
Doing a study for that.
Doing a study for that.
You are really focused, Ullas.
No, because so we are comparing the people on
that's the
chemotherapy,
way to go.
Immunotherapy, and TKIs.
That is the way to go. So we will come to that also in a while. That's great. Vinayak, do you think that there is a better vaccine for cancer patients? Now, the reason why I'm asking you this is that there's a lot of data on the mRNA vaccine, especially in cancer patients. There seems to be some data that the immunogenicity might be a little better with these mRNA vaccines. There's more data in the elderly who also are generally not expected to push up a good immunity. So do you think, at least in theory, we don't have clinical data as of now, that there might be a better vaccine for cancer patients among the many ones that are there?
Sir, I have no idea.
Okay, so again, so the answer is lay your hands on whatever you can get. Is that right? Because that's the right answer at this point in time. That's the right answer at this point.
Maybe when we decipher, I think the code will be over. I think so.
So that's being a little complacent, Vinayak. I don't think it's going to be over in the near future. It's going to keep coming. Let's hope that it is not. Let's hope I'm wrong and you are right. Right. So let's come to this dose delay issue. So Dr. Raja was right. Ullas was actually right that, when they gave the dose a little earlier, especially in cancer patients, they mounted a better immunity. So we are now moving to a point wherein Covishield, in general, seems to be 3 months from the first immunization. Now, there are 2 issues to it when it comes to cancer patients. One is that you're delaying setting in of that immunity. Second, the other, again, theoretical concern, I don't know whether it is based on clinical data, that if you have a wider population that is not adequately immunized, you have infections, reinfections, and more mutant strains that might actually come up. So the question is this delay likely to be counterproductive and counterintuitive? Let me ask Dr. Raja and then go to Dr. Acharya for his comments.
No, I sincerely believe that the delay is counterproductive and probably, as you rightly said, counterintuitive. And you also said a couple of minutes back that more political, unfortunately. And here, the logistics have been. I have to state that the logistics have been probably
getting policies.
Yeah, it has got messed up. That's what all of us. So I believe that, and I also want to mention that our very brief summary of the experience we were reviewing for another date with you all that when we looked at what happened to our cancer patients, we see that all cancer patients are not the same. I'm talking about cancer patients who had COVID and then recovered. What happened to them? We were looking at a quick audit, and then we see that the solid tumors, and then we saw the lymphomas, leukemias. Strangely, the leukemias are okay, a little better, and then comes the worst group, Hodgkin's, and then comes the non-Hodgkin's, and then finally the follicular lymphomas in our thing have done very badly, very poorly, and we have very high mortality. Post-recovery, I'm saying.
Okay.
So I think we have to really look at what to do to, we have to save our patients.
Absolutely. So earlier, quicker, the better, right? Professor Malhotra, and then after that, Professor Acharya. Professor Malhotra, so do you agree that this delay is more to do with logistics dictating policy rather than science dictating policy? What would be your opinion? I know there's no one correct answer, but what is your thought?
I think I would tend to agree with you, Senthil, that it is more out of convenience because of the limited supply of the vaccine. And my personal take is I would go for a regime which has been tested on 20,000 patients rather than a regime which has been tested on 1,000 patients. So we have the maximum data for 4-week interval. Until there is very strong data to contradict that, I would personally favor the 4-week schedule.
Great.
Now for vaccines for several viral infections, the schedule is 0, 1, and 6. What would be more interesting for me is that is a 6-month booster needed or not? And there was a little bit of chat between Dr. Parikh and myself that will you need to boost your immunity after 6 months? Maybe we'll be done and over with COVID-19 after 6 months. But that would be an important scientific question for me.
Absolutely. I think that's worth studying in a prospective fashion. Dr. Acharya, and then I'll ask Dr. Basin a question. Dr. Acharya.
Yeah. Sorry, can you just sort of repeat?
So I was talking about the delay causing more mutant strains. So even in the UK, is the delay more logistic rather than scientific?
Well, no. To be honest, delaying the second vaccine dose does leave cancer patients vulnerable. And
Correct.
That is the study which we have seen from the King's College of London, very recently published just in the month of May.
Right.
As far as which vaccine to give, now this is always this has been an ongoing sort of discussion, even in the US where they have Pfizer, Moderna, and then recently Janssen. So what they're saying is Johnson & Johnson, which has obviously their sort of arm is Janssen or Janssen as
Janssen, okay.
Yeah, so which is also sort of adenovirus vector type of vaccine. So they've said the efficacy is about 65 to 70% with Johnson & Johnson as compared to almost 90% with both Pfizer and Moderna. But then with Johnson & Johnson, you only require one dose, whether it's a cancer patient or a non-cancer patient. So using either of that would have an advantage, one or other way. But ultimately, the oncologist there and here in the UK and we virologists, immunologists say that get any vaccine that you can lay your hands on, whether it is Johnson & Johnson or Pfizer or Moderna or AstraZeneca, and give it to the cancer patient. Do not delay. Just a small point, which I wanted to add is, we have been saying why we need to give a vaccine and why is it so important for cancer patients. We all know that they are all immunosuppressed and they are all vulnerable. But there is another important feature, and which is actually quite important. See, we've looked at the second wave in India, and it's caused a huge surge because of the Delta variant. I would not call it Indian variant. I would call it
very infective.
Right? Yeah. So why has this happened? You see, there were a lot of socio-political reasons. There have been gatherings, religious, non-religious gatherings. There have been protests. There have been election rallies. All that. Do we realize something that a cancer patient, is actually a very important host from the point of view of the virus, because these are the patient where when they are infected by the SARS-2 virus, they actually provide a very good fertile breeding ground for mutations.
Absolutely.
And these are the patients, because their immunity is low, they actually escape detection, track and trace, because they don't produce symptoms immediately, as you would find in a normal a patient who's immunocompetent. So the virus stays for a longer time undetected, undergoes more and more mutations, and that is how we get a clinically viable variant, which became more transmissible. So I think one of the reasons why a cancer patient should be given vaccine as soon as possible is because to prevent mutations and variants. Because if you know, see, coronavirus is an RNA virus, and all RNA virus as a thumb rule are actually unstable because they don't have a paired strand. This coronavirus is a single-stranded positive sense RNA virus. So they are unstable. But coronavirus are not they don't mutate as much as a Ebola or those Lassa or those other type of viruses.
Right.
But it is because they've found immunocompromised host.
Absolutely. So, you may be actually peddling a lot of mutations, if that's the right word to use. Dr. Bhasin, you run a very busy lab too. You have a lot of data. So I'm coming to the question of the antibody levels waning away, because there's a lot of discussion in the chat box and of course in our panel also on the need for boosters. So do you have any data on looking at patients serially and telling, and saying when the antibodies fall to whatever you think is below a particular level that is necessary for immunity? Dr. Bhasin.
So see, we are currently in very early stages with regard to the antibody data. Because if you look at the first shot of vaccination in India was given just 5 months ago, less than 5 months. First shot was 16 January. So far we have seen antibody levels coming and developing. Although in last 10 days, I have seen some people on quantitative assay having lower values than their previous test. But whether it is an analytical difference or there is a fall in trend, it is yet to be seen. We can't very intelligently.
So I think you're saying it's too early for us to really say whether the antibodies actually wane off, and if they're waning off, how quickly do they wane away?
Most of the patients which we are seeing, if you look at in the first 45 days of vaccination, there were only a handful of healthcare workers who had got the shot. The larger population started getting vaccination after 1st of March.
Right.
And the second doses are recently completed.
You're correct. Your point is right. Your point is right that it's too early to really make a comment on this. So this is a summary on. Yeah. Go ahead.
I'm a little confused.
Okay, let's resolve your confusion. Yeah, go ahead.
All the panelists and including yourself, we all agreed around 40 minutes back that antibody measurement at the individual level does not make so much of a difference in decision making.
Absolutely.
But, but right now we are discussing immune responses. Is anything what we have is antibody.
Amish, you're right in a way. The reason why I was asking this question is at this point in time, the so-called best surrogate that we have is this. Though its applicability in day-to-day decisions is very, very limited, except at the community level. But if somebody says clearly that this is waning away, then there is a scope of looking at many other T-cell parameters also, and then come to a composite score to say that, okay, somebody's antibody level and the T-cell parameters are waning away, and hence, there might be a role for a booster. So I'm just trying to...
I completely agree with you, Senthil, and that is what I keep telling Vishu, that come out with a T-cell assay
a composite score
focusing only on spike protein antibodies.
As all our clinical trials have started, a composite endpoint now, right? So immune responses may be slow, the durability is unclear, boosters are likely to be necessary, though none approved so far. We should certainly look at methods to augment immune responses. We've discussed about this earlier, and based on available evidence, no vaccine is superior. Great. So we quickly come to our last part, which is, we've got 15 minutes. Sir said we'll go until 8:45, so I'm okay if all the panelists are okay with it. So we'll have a kind of a rapid fire now. So let me start with Ashek. Ashek, chemotherapy patients, when would you prefer to vaccinate them? These are practical points which many of our listeners may want to take home to use.
So all the patients on the chemotherapy, they can get vaccinations as and when available. I mean, I really don't think so there should be any delay in the vaccination. Okay. Only thing is that I will see to it they are not neutropenic. So there should be some neutrophilia recovery. That's the only thing which I will look at. And maybe if I really have to keep a day, I usually keep 7 to 10 days gap between the chemotherapy and the vaccination.
But that's the time they are likely to be neutropenic, isn't it, Ashik?
Yeah, so that is so more than 10 days.
So you want to do it later. You want to do it later.
Yeah, or maybe before that, give it before, and 7 days later, then you can give a chemotherapy maybe.
Vinayak, is there any good reason to say that you should not do it during the neutropenic period? Do we have data from other vaccines that if you give it during the neutropenic period, there is a negative impact?
I think more than the neutrophils, it is that lymphopenia which matters actually.
Correct. So generally chemotherapy, the conventional chemotherapy doesn't cause lymphopenia as such, isn't it? Though as part of the whole, total count going down, you get low lymphocytes also, but then.
Yes, I really feel that except for the hematological malignancy and maybe transplant, where the neutropenia will match the lymphopenia.
Right.
I'm a little meticulous, but otherwise I think
correct. So
great difficulty we get vaccine. I really don't want to put a spoke in that. I will defer chemotherapy by 2-3 days.
Okay, so you will defer the vaccination by 2-3 days. No,
sir, I'll defer the chemotherapy by 2 days.
I'm kind of getting confused there. Okay, so the reason why I asked you this, Vinayak, is the guidelines clearly say that avoid the period of neutropenia, so we should follow it. But there is some nice data with influenza vaccine that actually the immunogenicity is not lower when you use it during when you give it during the neutropenic period also. So we will follow the guideline. We will say that avoid the neutropenic period, but it doesn't seem to be that much of a problem to give your vaccine during that period also. So let me ask Raja sir, now that the pandemic is kind of, at least for the time being, on its wane, do you think we should straight away go and vaccinate our patients, or wait for the chemotherapy to end and then vaccinate? Because your immune responses may be better if you wait till the end of chemotherapy and do it, considering the present scenario, right? If the same question would have been a different answer 1 month ago, but is your answer any different today?
No, like what you said, it is also, these guidelines are also reflective of the what you call that level of pandemic, they say, and we are in a very, very high risk setting as most of them. So therefore, all these are to be taken out of our, all these obstacles have to be taken. The patients have to be immunized today and right away. And unless there is a neutropenia, one would have to be, because of the guidelines, one would like to wait. But other than that, everyone today is the
absolutely answer. Absolutely today, and do it right away. I think that's the correct answer. Absolutely. Nikhil, doing it on the day of chemo, logistically easy. Do you think that's a good idea, bad idea?
Logistically, definitely easy. Having said that, I would probably try to push the vaccination maybe day 14.
Okay.
From if we are talking about the once in a 3-week cycle.
Right.
That is what I do mostly. That's after I'm convinced that probably there is no further neutropenia or for that matter.
So avoid the day of chemo, the problems with steroid and side effects and so on and so forth. Absolutely right. Chandrakant, immunotherapy, any interaction with vaccines?
So no, sir, I don't find any difference.
There is no interaction. You can straight away give it any day. Professor Hemant Malhotra, steroids, I think that is something that is very less stated in most of these timing of vaccine guidelines. We, in medical oncology, we use steroids like water, especially in hematological malignancies. So if somebody is getting, let's say, more than 1 milligram per kg of steroids and so on and so forth, myeloma, 40 milligrams of dexamethasone once a week, do you think these are times that you should avoid the vaccination because the immune response is likely to be less? So what do you really do in your practice?
So guidelines are not very clear on this. As far as I'm not aware of very clear guidelines.
Right.
I would in my patients vaccinate, not wait, with the anticipation that the immune response might be weaker. But having 40 or 50% immune response versus a 90% immune response versus having no immune response is much better. So I would vaccinate, maybe consider a booster after finishing of the treatment, but I would follow the regular vaccination schedule, steroids or no steroids, and whatever the dose of steroids.
Okay, so Ashek, do you agree with Professor Malhotra? Steroid, no steroid, it doesn't matter. Let's go and give a shot. And
yeah,
then,
so I mean, yeah. So I even spiritually will say the same thing, except, I mean, transplant, I don't think there is any situation I would like to delay the vaccination.
Okay, so we'll come to the situation that Amish was actually talking about. And so do we all agree that though the pandemic is on its wane, at least for the time being, that we should not wait for completion of therapy? Because one of the guidelines clearly says that either you finish both the doses 2 weeks before the start of any cytotoxic chemotherapy, or if you can wait, you wait until your cytotoxic chemotherapy is over and then do your vaccination. Do we all agree that we should not wait, at least in our country at this point in time, for that to happen and go and give a shot as soon as we can? Chandrakant, sorry, you agree? Nikhil?
Sir, we will not wait, sir.
We will not wait.
Vaccine is the priority.
Excellent. Vaccine is the priority. I agree with you. Nikhil?
Could I just come in?
Yeah. Please go ahead. Please come in, Dr.
So basically, the guidelines which we have, which have been drawn by the chemotherapy board here, obviously in association with the vaccinators, the Joint Committee on JCVI, as we call it. So the absolute contraindication for vaccine and chemotherapy is you should not give it on the same day of patients receiving cytotoxic chemotherapy. Right. You can give it the second day or third day. Patients on proteasome inhibitor like bortezomib or ixazomib, you should not give it on the same day. Then patients who are acutely neutropenic, not chronic neutropenia, acutely neutropenic without GCSF, platelets more than 20, you just sort of wait just for a couple of days to make sure that the platelets are coming up. And the only immunotherapeutic agent where you really have to wait for a few weeks is rituximab, because rituximab is the only immunotherapeutic agent which acts against B cells. And B cell is the most important part for immunity in COVID to launch immune responses, because they are the memory cells.
Absolutely.
So that's probably how
rituximab is on your screen, Dr. Acharya. Very, very nice inputs. Chandrakant, Dr. Roshni Pandey wants to know, what do you do during ALL induction? You use plenty of steroids, 28 days. So should you be giving the vaccine at that point in time? What are the guidelines saying?
So I would, so ALL induction is an intensive phase where the B cells may not be that effective. So I would consider induction and at least some immune reconstitution, and then I would.
Right. So the guideline says, Dr. Roshni, that you should be giving your vaccine during the maintenance phase, not during the induction phase or the early intensification phase where a lot of steroids are used. The efficacy is likely to be less. Raja sir, I want to bring you here. Again, you spoke about follicular lymphomas faring very poorly. We know one of the reasons could be rituximab and poor immunity, but that would not definitely explain why they went home and later died. But like Amish clearly pointed out earlier, and Dr. Acharya have pointed out earlier, there is some time gap before or after. But again, in the same breath, we are looking at a time when community transmission is quite high, and you rightly said we need to vaccinate immediately. So do you think that at least the little immunity, like Professor Hemant rightly pointed out, to generate some T cell memory in the absence of B cell recovery and so on and so forth, would still be worth it going and giving it, considering the fact that the incidence of infections in the community is so high? Do you think there is some science or substance to that? Considering your data, which I think is very valuable and absolutely right. We've seen patients who are on rituximab doing the worst on COVID. In fact, we tell them the mortality is nearly 100% when they admit them. Your thoughts on that, Dr. Raja?
So, I mean, we also learned along the way, earlier, first wave and the second wave, and we clearly understood that all the patients whom we have lost for lymphomas, they have all been rituximab treated, and middle of the treatment, they got caught. And then some of them went home to come back with a very bad lung, and they did very poorly. And we also found in our quick analysis that patients who had been admitted on treatment, and then they come back and get admitted for an incidental COVID infection. And when they are neutropenic, at that point in time in the middle of the treatment, and if we had used GCSF to improve their neutrophil count, we seem to find that those patients also did terribly as far as the lung inflammation and the cytokine storm went on. So, and then we looked at relevant literature, and there is enough literature to suggest that there is a correlation with the GCSF use right in the middle of neutropenia or right to NIAV. So now, if I have a choice, all those lymphoma patients, vulnerable patients, before I start any treatment, if I can vaccinate them, I would do it immediately. But if they are already on the middle of the treatment, and if they have been exposed to rituximab, I would definitely wait for at least 4 weeks. And now what we have done is all our patients, if they had a touch and go, whatever, we don't worry. We just drop the rituximab, and we find that to be a very bad agent. At this point, we are willing to sacrifice rituximab. These are some of the things that we have adopted recently.
Absolutely correct, sir. So in fact, for us, for patients who are starting and who are not vaccinated, we've actually skipped the rituximab first cycle, given the vaccine, gone ahead with the first cycle, all sorts of jugglery that we have all done to make sure that it's safe for our patients to go through. Vinayak, do you have any thoughts on this? Dr. Raja had very useful points to, offer on rituximab and vaccine itself.
Yes, sir. I think B-cell immunity does matter. So I'm not done actually. We haven't had patients who was on rituximab with the COVID infection. But hearing the stories, I think it would be.
I think it's a point worth looking at, Vinayak, isn't it? Because they do very poorly if they get COVID infection. And finally, vaccination of medical staff, caretakers, and family is very, very important in protecting cancer patients from the infection itself. Professor Malhotra, I want to ask you this question, which is, should you think we should make it obligatory to get vaccine done, considering the fact that we're all healthcare personnel? It's for our safety, our family's safety, and then very importantly, our patient safety also. Do you think it should be obligatory?
I think this is an extremely important aspect, Senthil. I mean, in addition to owing yourself your own safety, you're also part of the social system, you're also part of the social milieu, and it is also your responsibility not to transmit the virus to other people. And this holds particularly true if you're a medical professional, if you're interacting with several compromised individuals. So I do think that somewhere down the line it will become mandatory. When the first wave was starting, I'll just take 5 seconds. Somebody sent me a very nice forward that the vaccination is like the safety belt. The safety belt is compulsory. If you don't wear it, the cop is going to fine you. Similarly, vaccination, if you don't get it done, you will be fined by the government or not allowed to work. And the safety belt will not prevent you from having an accident, but if you have an accident, it will prevent you from injury and prevent you from death. So that is the place of the vaccine and the place where the vaccine should be.
Great. So I think over time, it should be made obligatory is what I think. So before we go, one question again to Dr. Raja. Sir, we need more vaccines to come into the country. You pointed out regarding your logistic issue as far as travel is concerned. So one of the things that these vaccine companies have been demanding from the government is indemnity, and that they should not need to do bridging trials in this country. So one is, I want you to opine, and then Parikh sir to opine, and then we close. Do you think we should grant all these and then get those vaccines into the country because we need them very badly, or should we stick to whatever we're doing?
Difficult. The situation is overwhelming. What we went through in COVID-2, second wave is really overwhelming. And then you have this heterogeneity of Indian vaccine makers, and you have the international vaccine maker. And then indemnity as an issue. Tomorrow, when there is a trouble, how do you define all that, and how are you going to really define all the co-variables? And so, in my opinion, there should be a stringent approval setting. Once you approve, I think this is an emergency situation, and most of them are qualified as emergency use. In my sincere opinion, I have a patient who had a vaccine and have a stroke. I can later on, have a stroke, and we have documented MRI and all that post-vaccine. Okay, so but having said that, I do believe this is an emergency situation. This is like an emergency surgeon who has to operate, and he's less, equipped with all the info and all that. Therefore, I would highly support a uniform indemnity once the vaccines pass a certain level of standard to come into the public use.
Right. Good point. Professor Parikh, before we end, I want your comments on indemnity and bridging, the need for bridging trials.
I feel that waiving of the indemnity and giving them pharmaceutical companies this blanket permission is a very bad precedent.
Absolutely.
So subsequently down the line, they will ask for day-to-day treatment and for common illnesses also. So I am, as a my personal opinion is that if they want to manufacture, test and sell any medicine, including vaccine, they should, be liable for whatever responsibilities they have.
Absolutely. I don't think we should give them any blanket right to do whatever they want in the market. I absolutely agree that there should be some regulation there. With that note, I want to thank specifically and especially Dr. Mukul Acharya and Dr. Bhasin for giving the very, very important inputs. It was so good. All of us learned so much. So till the time that we can get universal vaccination and, at least 75% of our population will be vaccinated, I think it's important to make sure that there is social distancing and make sure that you're doing the right distance and not like what the spacing on the school bus looks like. Thank you so much.
Sorry,
Parikh,
can I just quickly come in just for a minute?
Oh yes.
I think someone raised a very important question. Whether I've had infection and whether I should have the vaccine or not. Someone said that, and what gives you better immunity, infection or vaccine? And that's very interesting. So now we've had trials, and I'll tell you in a minute. See, someone who's had a mild infection will launch a very good response, and then they actually can just have one dose of vaccine. We are talking about immunocompetent patients. We're not talking about immunocompromised or cancer patients. So it's all right for them just to have one dose of vaccine after having had a mild form of COVID-19 infection. But someone who has a moderate to severe form of COVID infection, who has required ICU treatment, high dose steroids and all those sort of cocktails, see, the immunity produced by those type of infection is a fractured immunity, because when I say we, it's UK and USA, we've had some research done, post-mortem research done on those patients who unfortunately passed away because of severe infection in cytokine storm. We studied the lymph nodes. We did a lymph node biopsy, and we found that the B cell germ center is very rapidly destroyed by the COVID-19 infection. So these are the patients who may, even though may exhibit some neutralizing antibodies, their memory cells are completely destroyed. And once their neutralizing antibodies wane over a period of time, they won't be able to launch a response on a re-exposure to the infection. So that is very important, why vaccine is a must, and rather than infection-induced immunity. That's all.
Okay. I think thanks so much for all your comments, Dr. Acharya.